Hello, my name is Dr. Thomas R. McCarty. I am currently a medical resident at Yale University School of Medicine in New Haven, Connecticut, and I'm one of the authors of the recent study published in GIE entitled Cost Utility of ERCP-based Modalities for the Diagnosis of Cholangiocarcinoma and Primary Sclerosing Cholangitis. Today I'm pleased to have the opportunity to discuss with you briefly our cost utility study and talk for a moment about the current challenges that exist in diagnosing cholangiocarcinoma and primary sclerosing cholangitis, or PSC. As many of you know, PSC is a cholestatic disease that is associated with an increased risk for the development of cholangiocarcinoma. This risk of cholangio has been estimated to be around 1.5% annually, with the projected lifetime risk estimated to be around 15 to 20%. Although these patients are typically screened annually for cholangiocarcinoma, the lack of an effective early diagnostic marker significantly affects outcomes. This, coupled with the need for alternative treatments to a curative resection, produce a really dismal life expectancy, estimated to be around 6 to 12 months. The reason for this poor life expectancy is in part due to the fact that PSC patients with cholangio present a real diagnostic challenge for clinicians. Currently, bile duct brushing for cytology is probably the most common ERCP method for tissue sampling in patients with PSC, and this is likely due to 1. The availability of the procedure at endoscopy centers, as well as the technical ease of the procedure itself. However, it is important to note that while bile duct brushing may be the most common, there are several other ERCP-based modalities that are also available. Yet, despite the availability of numerous modalities, these techniques are associated with a high degree of inter-operator variability and typically have a poor sensitivity and negative predictive value. This is in part because it is very difficult to distinguish cholangiocarcinoma from chronic inflammation and dominant strictures in PSC. Furthermore, until recently, there have not been definitive studies to suggest one clearly superior ERCP modality over the others. In the absence of any formal organizational or societal guidelines, we recently published a study demonstrating single-operator cholangioscopy to be the most accurate ERCP-based modality for the diagnosis of cholangiocarcinoma in PSC. With this information from pooled accuracy of a variety of ERCP-based modalities, we then set out to design, in this study, a cost-utility analysis to determine the most cost-effective strategy in patients with PSC-induced biliary strictures. To determine the most cost-effective strategy, we created a decision analytic Markov model to describe the possible outcomes for a PSC patient presenting with a suspicious biliary stricture. False positive tests carried the added cost of unnecessary ERCP-based testing, inappropriate transplant evaluation and treatment, as well as misappropriation of other resources such as the potential need for surgical resection or chemotherapy. While false negative results place patients at a higher risk of developing cholangiocarcinoma or worsening disease progression. Again, these would incur additional unintended downstream treatment costs and increased mortality. Using a Monte Carlo simulation to assess quality-adjusted life years and incremental cost effectiveness, we compared 5 different ERCP-based modalities, including bile duct brushing for cytology, brushings for FISH trisomy and polysomy, intraductal biopsy, and single-operator cholangioscopy. Ultimately, our cost-utility analysis demonstrated that single-operator cholangioscopy appears to be the most cost-effective diagnostic modality for cholangio in patients with PSC. Despite bile duct brushing for cytology being an inexpensive and more commonly available sampling technique, single-operator cholangioscopy was demonstrated to be more cost-effective. Cholangioscopy as compared to ERCP with brushings for FISH polysomy produced an incremental quality of life year gain of 0.22 at an additional cost of approximately $8,500. This resulted in a base case incremental cost effectiveness ratio of approximately $39,000. We then performed deterministic and probabilistic sensitivity analyses that demonstrated diagnosis with single-operator cholangioscopy was cost-effective at a conventional willingness to pay threshold of $50,000 and $100,000. At this time, ERCP-based modalities, despite being far from an ideal diagnostic choice, are pivotal to early detection of cholangiocarcinoma in patients with PSC-induced biliary strictures. Going forward with this data, it is our hope this study will provide a basis for future diagnostic algorithms and help to create guidelines specific to the PSC population. Given the overall poor life expectancy associated with cholangio and PSC, both accurate and cost-effective strategies are certainly needed and should be encouraged. Again, to summarize the results of our study, based upon currently available data, single-operator cholangioscopy appears to be the most cost-effective diagnostic modality for cholangiocarcinoma in patients with PSC-induced biliary strictures. I'd like to take this opportunity to thank GIE for the opportunity to discuss our results here today, as well as my co-authors for their tremendous support and efforts. Thank you very much for your attention today. I hope you enjoyed this GIE interview series. Thank you. Have a good day.